like to take a few moments to give you a brief review over Ajanta Pharma. I would request the slides to be shared. Please put on the first slide if possible. Okay, yeah. So let me begin with who we are. I'm not able to change the slides actually. Huh, yes. So Ajanta Pharma is an Indian multinational pharmaceutical company serving global healthcare needs since 1973, with our core values centered around empathy, innovation, and technology. Over the years, can you, yeah. Over the years, Ajanta has grown into a global organization with a presence across 33 plus countries, a portfolio of 600 plus products, and more than 13,000 Ajantites representing over 30 nationalities. One of our of the key pillars of Ajanta Pharma is the research and development. Our advanced R&D centers bring together more than 850 scientists and covers the complete development value chain from synthetic development and analytical development to formulation development and regulatory affairs. Ajanta has a strong presence over multiple therapeutic segments, including cardiology, ophthalmology, dermatology, pain management, nephrology, and gynecology. Another important strength is our extensive field presence. Ajanta has 20 teams, more than 3,750 medical representatives, and covers over 250,000 doctors. Our portfolio includes 350 plus products, with 155 plus products being first to market, reflecting our continued focus on innovation and differentiated healthcare solutions. Moving on to manufacturing, Ajanta has 7 state-of-the-art manufacturing facilities, including 2 years FDA approved plants, which is Python and Dahej. And importantly, our USFD approved facilities received approval for zero observation, which is a strong reflection of our commitment of quality and regulatory standards. At Ajanta, our commitment to healthcare is our at Ajanta, our commitment to healthcare is beyond the products. Through our CSR activities in year 2025, Ajanta has supported more than 54,000 free cataract surgeries, over 3,000 family planning surgeries, and more than 69,000 malnutrition treatment, along with several other initiatives. As you can Our commitment to excellence and innovation has also been recognized through several prestigious awards and recognition. As you can see on the screen, Ajanta Pharma has received recognition across various platforms, including the Great Place to Work certification being awarded consequently for past 2 years. We are also particularly proud to share that our managing director and joint managing director have been recognized with prestigious award, the Time Young Maker of the Year by the hands of Honorable Prime Minister Narendra Modi. And as we say, striving to be your scientific partner, we look forward to continuing this journey of learning and collaboration with you. And with that, I come to the most important part of today's evening, our scientific session. Last year, we had the privilege of initiating Orthoquest conducted in association with Indian Orthopedic Association. Building on the success and learning from the last year's initiatives, we are pleased to continue this scientific journey this year as well. Today's session marks the first module of this year's Orthoquest 2.0 series, and we are delighted to begin with the series with the topic From Cartilage Injury to Osteoarthritis and the Role of Collagen Type 2 in Post Arthroscopic Knee Preservation. It is now my honor to introduce our chairperson for today's scientific session. We are delighted to have with us Dr. Raju Raman, who can you please Yeah, thank you. We are delighted to have with us Dr. Raju Raman, who is an accomplished orthopedic surgeon. Dr. Raju Raman holds MBBS and MS in orthopedics and currently serves as the Secretary General of Indian Orthopedic Association. He has received several prestigious recognition, including Siliguri Gold Medal Award of West Bengal Orthopedic Association and the A. Mehta Gold Medal from Indian Orthopedic Association. He has also held several important academic and professional positions, including Secretary of Indian Arthroscopy Society, Honorary Secretary of the West Bengal Orthopedic Association, Secretary of the West Bengal Association of Sports Medicine, and the Chairman of the Inland Fellowship of the Indian Orthopedic Association. His contributions also extend to academic examination, professional association, sports medicine, arthroscopy, and postgraduate education. Thank you, sir, for joining us today. It's an absolute privilege to have you with us. So, without any further delay, I would like to hand over session to you. Over to you, sir. Thank you.
Thank you, Pavna, and thank you, Team Ajanta, for this wonderful webinar. So I would like to please continue with the introduction slide. I would like to introduce our esteemed faculty member who are participating today. Rahul, can you share the slides? So we have our President of Indian Orthopedic Association, Dr. Naveen Thakkar. We had a welcome note from him, and he is President of Indian Orthopedic Association, past President Gujarat Orthopedic Association. He was our past Secretary of General of Indian Orthopedic Association also. He pioneered the IOA website development with transparent online election, providing free bone and joint surgery. He has Presidential Appreciation Award at IOCON Coaching 2016 for dedicated IOA activities. He has received the prestigious Shushruth Award in IOCON 2026 in Delhi, IIM Ahmedabad Innovation Gold Medal, Inventor of India Mid 2006, KT Dholakia Gold Medal, IOCON 2007 at Kolkata, SP Mandal Rational Orthopedic Gold Medal, IOCON 2008 in Bangalore, Gold Medal NELSCON 2012 Udaipur, Silver Jubilee Oration, IOCON 2012, IOA Conference Oration Cochin, IOCON 2016, Incubate Center for Innovation and Incubation IIM Ahmedabad, first Indian orthopedic surgeon who got 2 US patent, and many more awards. Welcome, Dr. Naveen Thakkar, sir, President Indian Orthopedic Association. Next slide, please. We have Dr. Naresh Agrawal, a senior orthopedic surgeon and our teacher and mentor from Ludhiana. He is consultant orthopedic surgeon, joint and spine center, Ludhiana. He has done his MS from BHU and FICS and MCH from Liverpool. He has been ex-international expert orthopedics for the country of Afghanistan, and he has worked in India and Afghanistan and UK with fellowships in US and Europe. He has been ex-professor of arthroplasty and traumatology, DMC Ludhiana. He was ex-professor and head orthosurgery, CMC Ludhiana. He has 50 years of experience dealing with in orthopedics, traumatology, arthroplasty, and even he is a very pioneer in regenerative medicine also. He is a designer of Ludhiana Liverpool XFIX system and a couple of more equipments. He has delivered more than 175 talks nationally and internationally, published in national and international journal. He was founder, President-elect NAILS 2002 and 3, President NAIL 4 and 5, and Vice President IFAS 2014 and 15. Welcome, Dr. Naresh Agrawal, sir.
Thank you, Dr. Rashid Raman. Thank you.
Yeah. Next slide. Yeah. So, without wasting of time, and this is the Orthoquest, I would like to, and our theme is from cartilage
Sir,
injury.
Dr. Jawar Jatwa, sir.
Jawar Jatwa, sir, presentation. Hello. Can you share this slide? So we have our another expert speaker today, Dr. Jawahar Jatwa from Ahmedabad. He is a consultant orthopedic surgeon in Ahmedabad since 1984. He is associate professor of orthopedics at Narendra Modi Medical College, Ahmedabad. Co-chairman and chairman of Scientific Committee IOCON 2026 Gandhinagar, Ahmedabad this year, and chairman of the IT and Web Committee of Indian Orthopedic Association. He has been advisory expert of training of AI for fracture detection by AI, author of chapter in the 5th edition of Tanna Interlocking Book of Modified Ender Nailing. He has received the gold medal, SP Mandal Orthopedic Gold Medal for research on innovative implant by the Indian Orthopedic Association 2017. He has received the Best Paper Prize on osteosynthesis by epoxy resin, and he has indigenously designed new external fixator, shaping press, JJ compression clip, point supporting plate, Ahmedabad bolt, Gujarat guide, modified underlining, only sponge technique and reduction book technique. Developed the first window-based medical practice software in 1996, recognized and qualified faculty of National Trauma Management Course and EMT Emergency Medical Technician, Chief Medical Researcher and Advisor of Drug-Eluting Orthopedic Implant, past President of Ahmedabad Orthopedic Society and Gujarat Orthopedic Association, and EC member of Indian Orthopedic Association. He has presented many talks, conducted workshops, and presented paper and published article in different national and international journals. Thank you, Jawahar sir, for joining. And we have our Dr. Keyur Patel. He is a neurologist, and he will be joining as an observer from the Gujarat Medical Council. Welcome, Dr. Keyur Patel, sir, for this webinar, Orthoquest webinar. And now I would hand over to Dr. Naresh Agrawal, sir, for his talk. Over to you, Naresh, sir.
Thank you very much, Dr. Rajiv. Just before I start, I'm a little bit curious that there is another platform. Will they be able to hear us, and will we be able to know what questions they are asking?
Yes, sir. So all the question will come, will be shared in the chat box, sir. And at the end of the session, we will discuss on every question, sir.
All right. All right.
And they can hear you, sir. But
Okay.
the interaction will be through this platform only. So directly they can't ask questions, sir. Please,
Right.
sir.
So I will share my screen first, and then we start. Can you see my screen?
I think it's being shared, sir. Let me check. Yes, sir. Please share in presentation mode.
As we said, we are talking, the subject of the today's webinar is post-arthroscopy knee preservation with collagen and other like supportive medications. So I am going to talk about arthroscopic preservation technique that we have developed over last 4 decades for saving the knee joint. How this journey has evolved and what we are doing today. That is what I'm going to talk about this. As Dr. Rajiv Raman said, I've had an opportunity to work in different parts of the world, and I've tried to bring learnings from all the places and put those learnings behind this talk. At the outset, I'd like to say there is no conflict of interest anywhere, even in this talk, for me. We all know success of total knee replacement has been one of the triumphs of last century. I started total knee replacement in 90, and 36 years I've been doing total knee replacement. But over the years, pictures like this with crooked limbs becoming straight, started walking, they have become commonplace in every orthopedic department now. So much movement we were able to get. However, after 15, 20 years, we realized that though we claim 95% survival after 15 years, but excellent and good results are only about 75 to 80% patients. 20 to 25% patients are not happy even after a successful total knee replacement surgery. Why they are not happy, what the patient actually wants, what they are dreaming of. Patients, when they come for total knee replacement for the problem of their knee, they dream that it should last longer than their life. It should be a painless procedure, they shouldn't feel much pain, and there should be no complication. But 15, 20 years back, we asked ourselves this question after having experienced knee replacement, that is that possible? And we thought that was not really possible, as we know that every patient, 15, 20 to 25% patients would not have. So we thought, let me look at my cases, what were the problems and how I could have avoided them. So I looked at my first 500 patients with 5 to 20 years follow-up. There was some share of problems that I had, but I realized that these problems were very few, about 5-7%. And therefore, I thought single surgeon's experience is not enough to make evidence-based recommendation. It has to be total pooled experience from around the world. And then we can make some recommendations to improve our results about total knee replacement. So I read all that was written about total knee replacement in English literature, more than 5,000 articles. And I found answers to most of my questions, how we can make it last long, how we can make it pain-free, how we can make it minimal complication, and how we hope that with that patient will become happier. That 20 to 25% gap will cover. So we found out from the results, the gist of those 5,000 studies was this, that how to survivorship was affected by tibia, discomfort, post-op pain, blood loss, comorbidities, technique. If we could work on all these things, mortality was mainly because of cardiovascular accident, and reoperations were due to patellar issues. So if we could address these, as there were already outlines in the literature, we could definitely fulfill the dream of the patient. So we made a standard operating procedure in our department, in our center, that this is what we will be following, and this is what we have been following for about 20 years now. But what we have learned, that after this protocol, this has helped improve post-operative recovery, reduce pain and complications. Definitely. But dissatisfaction rate still there. 15-20% patients are still dissatisfied. So I thought, what is the problem? We have studied everything about total knee replacement, still patients are dissatisfied. Then I thought, let me look at the osteoarthritis all over again. How are we managing them? I realized that when the pain first starts in the knee, it takes 5 to 15 years of journey before we do knee replacement. And during this 5 to 15 years, our prescription basically remains the same, which is pain relief, physiotherapy, and maybe supplements, and maybe an intra-articular injection here and there. And then at the end, when it's grade 4, we say total knee replacement. We feel very happy that we've done a total knee replacement. Now I asked a question to myself, is this victory or defeat? I thought it was defeat of orthopedics. Why we could not stop the progression of disease when the patient came to us first? Like me, there the world who feel that TKR, despite being a revolutionary operation, is a defeat of orthopedics, medicine, and science. I came across this book, Unhappy Total Knee Replacement, published from Europe, so a couple of years back. So not only me, many people around the world are concerned about unhappy total knee replacement. This is a study from our own country, the busiest joint replacement center. They found that in 2 groups of patients, the dissatisfaction rate in elderly group, we were very senior, was 20%, and in relatively younger patient, it was 35% dissatisfaction rate. From our country, the figures from the expert center. Is that acceptable? Not really. Despite these, dissatisfaction rate, there are other problems with knee replacement, that it becomes an insensate knee. We cut ligament and we replace bone with metal and plastic. It becomes an insensate knee. Intra-articular sensations are gone. Despite survival, there is dissatisfaction rate. Periprosthetic fractures is a pandemic waiting to happen. And what is more concerning is that 1-year mortality after a periprosthetic fracture can be up to 45%, which has been reported in literature. Revision surgeries are again increasing in incidence with decreasing success rates and higher complications. Friends, osteoarthritis is a painful and disabling disease, and it's going to become the most common cause of musculoskeletal pain very soon, osteoarthritis knee. Still, the paradox is that there is no accurate tool for predicting the risk of onset of osteoarthritis, nor are there any approved medication to address the disease of osteoarthritis. We rather take pride in changing our tools from motorized instrumentation to computer to robot and now to humanoid AR, VR, and AI inputs. I asked again, I was just, I thought, is our focus more on machines and less on the disease or biology? And should we not be working on stopping the progression of disease rather than just changing our tools and coming out every few years with a new toy? To answer this question, I again read, this time not total knee replacement, but this time osteoarthritis. What exactly is the disease process? Every elderly knee does not develop osteoarthritis, only some develop. and there are some factors which predispose a person to develop osteoarthritis. These factors can be local or general, and mechanical or biological. All these are documented in literature. Some of them are modifiable, some of them are not modifiable. Now, once we know that all these factors, mechanical, biological, local, general, they predispose a person to develop osteoarthritis. What exactly happens in osteoarthritis? We have been traditionally thinking that it is just wear and tear of the cartilage, but not anymore. There is enough evidence in literature now, and every article has shown on pathology and local and systemic as well, that this disease involves everything in and around the joint, subchondral bone, subcartilage, synovium, capsule, ligaments, fat pad, muscles. Everywhere there is inflammation, and inflammatory enzymes are raised in every tissue. So then what is actually the pathogenesis of this? Friends, to cut the long story short, without going into the literary details, the gist of the literature today is that the osteoarthritis of the knee is a chronic low-grade inflammatory disorder, which is slowly progressive with immune-mediated pathology. In other words, osteoarthritis of the knee is local manifestation of this chronic systemic disorder. So it implies, and there is enough evidence for that also, that osteoarthritis and rheumatoid arthritis are two ends of the same spectrum of disease process. Only thing in osteoarthritis, inflammatory markers are not raised as much as they're raised in rheumatoid arthritis. Friends, what should be the treatment then of osteoarthritis? That is what we are after. Osteoarthritis knee, if it's a local manifestation of a chronic systemic inflammatory disease, it is no-brainer. The treatment has to be local as well as systemic. We target the local organ and treat the systemic inflammation. How do we do that? Local treatment has to be biological and mechanical, because in case of knee, quite a few patients develop deformities. So deformity will not be corrected by any biological or medical treatment. For that, some intervention will be needed. And biological treatment should address the inflammation in and around the joint. Friends, there are a variety of drugs which are being tried and practiced in various parts of the country for local control of the disease around the world, with very good results and in different phases of clinical trials. However, which are being routinely used for many years now and have become very well accepted around the world, some orthobiologics. Autologous orthobiologic products from blood, bone marrow, and fat, and allogenic orthobiologic products from placental tissue or even bone marrow have shown very good results, and they are being done at many places around the world. Lately, in last decade, ozone has become very popular, the molecule intra-articular oxygen, ozone. That has given very good results in relieving osteoarthritis symptoms. As far as mechanical treatment is concerned, then we know all that. We have been doing this variety of conservative options, braces, wedges, physiotherapy, and then variety of osteotomies. We all know that. We all been doing that. What is latest is in correction of varus deformity is a medially implantable shock absorber approved by FDA about 4 years back. Very good encouraging results, minimally invasive procedure. However, what is very, very new and what is very innovative is from our Professor Jignesh Patel of Surat. Pie crusting of anterior 1/3 of the superficial medial collateral ligament and pars insanius, and then giving a valgus thrust. Under local anesthesia, you correct the malalignment, then maintain it with a brace and physiotherapy. We do all these procedures, whichever is necessary. Coming to the systemic treatment, friends, the target of systemic treatment is to control the systemic inflammation primarily. And then at that age, there is metabolic imbalance, osteoporosis, comorbidities, all that have to be looked after. Again, variety of drugs being tried for targeting the systemic inflammation in different phases of clinical trials. Some are being routinely used and good results, promising results, but no definitive formulations as yet in the market. However, couple of years back, there was a review of all clinical trials which targeted the systemic inflammation to treat osteoarthritis. And you would be surprised that practically all the DMARDs that we use in rheumatoid arthritis have shown to be effective in osteoarthritis, including very low dose steroids. For but 25 years continuously they have used, and they have found it to be effective. So all these DMARDs, well reported in literature that they are effective, or osteoarthritis is amenable to these. It is the lack of positive diagnostic tests which have usually deprived the patients of appropriate treatment. We know that they are amenable to osteoarthritis, amenable to DMARDs. Now it is being still worked on, various regimes, various doses, low frequency, all that is being worked out. So friends, 3 or 4 years back, we thought, once having read all that, what should be my practice? What should we use in our country? What is good for our patients, our circumstances, our resources? So we made a protocol for a local treatment and systemic treatment. What is this local treatment? Local treatment consists of, apart from pain relief, biological, we do arthroscopic knee lavage with couple of liters of ozonized saline under local anesthesia. Then we inject high molecular weight hyaluronic acid. All this is based on the evidence in literature. And then we give plasma rich in growth factors or autologous growth factor concentrate. We give 3 doses of these, and we give 3 doses of ozone also intraarticular. This is our local biological treatment. Mechanical treatment, mostly Professor Patel's needleplasty suffices. Sometimes we do osteotomies if necessary, and of course we do lateral heel wedges and braces to maintain the corrected position. Friend, this has not evolved over 2 years or 3 years. This process, the local treatment, has evolved over 4 decades. For about 4 decades back, when arthroscopy came, it was not yet available in India. There were reports that just knee lavage with arthroscope helped improve the knee pain for some time. So we started doing knee lavage with a needle, and that helped in 1980s, early 80s. Then the next 2 decades were dedicated to TKR, and then arthroscope came, arthroscopic debridement became popular, and hyaluronic acid came into practice. Then next in 2000, the debridement went out of the window, because it was shown that with debridement or meniscal debridement and meniscal removal, they're all torn in osteoarthritis, the degenerative process is hastened. So no debridement, only wash. Take out the debris and take out the toxins and enzymes. And then hyaluronic acid, of course, we added for conservative treatment, and TKR was continuing its ascent. But in last few years, to lavage and hyaluronic acid, we have added first PRP, which has been now replaced by growth factor concentrate, and the needleplasty. So that is how, in our hands, the treatment has evolved over the last 4 decades. So friends, I will show a quick video, a couple of minutes video, as to how we are doing this procedure under local anesthesia without any admission as an OPD procedure. Everything is done as an OPD procedure. You can see this patient. Oh, sorry. I have to. Let me play this video. Yes. Is this video playing or not playing? No, I think this video somehow is not playing today. I will skip this video and move forward. Now, as far as local treatment is concerned, apart from what I said, if the patient comes so late, there is bone resorption, there is subluxation, there is fixed deformity, there are big loose bodies, we have to do TKR, and we do TKR, definitely, yes. And in then selected cases, we add systemic treatment as and when necessary. Here, patient is more happy. Now, coming to after local treatment, systemic treatment, as I said, objective is systemic control of systemic inflammation and putting the disease in remission. We do that with low dose, low frequency DMARDs, and then we treat comorbidities. And after this, we add some general supplements, which include Cisodoas and collagen type 2 in safe doses, all these supplements and frequency. What we have to tell the patient is that systemic inflammation is a chronic condition, like hypertension, diabetes, rheumatoid arthritis, etc. The treatment continues for a long time. The doses can vary depending on the activity level of the disease. They can go up and down if the disease has gone into remission. At the same time, we don't have to promise any miracles at that age to the patient, because we can't prevent aging. We can only improve quality of life, maybe pain-free quality of life. And that is what patient has to realize. There has to be shared expectation, because if the patient thinks that some miracle is going to happen, that will never happen. We are not capable of doing that. So what are the low dose, low frequency medications I'm showing here? This is what we give, but this we individualize and use selectively for patient because there are multiple drugs. We have to see what the patient, if there's some patient is intolerant, we remove those drugs. We give very small drugs and then we monitor them closely. Dr. Mukherjee, a close friend of mine, has been giving a variety of medications, but we have started giving lesser medications, but at the same time ensuring that disease goes into remission. Results are very good, friends. Now, in last couple of years, we have done about 154 knees. Only 3 of them have gone on to total knee replacement. Majority of them are grade 3 and 4. And the 3 knees in 2 patients which went on to do total knee replacement, they were all grade 4. And 92% have shown excellent results and are very happy with the treatment, with about 6% being partially happy. For 1 year, we are doing added ozone to our protocol. And what we have observed is that with ozone, pain relief can start within 24 hours. Earlier, it used to take 3, 4, 5 weeks before the pain relief started. But now it starts within a day and patients are very happy. Again, this is a one X-ray. I'm not sure whether it will show or not show. This was a patient who was on bed for 1 year, unfit for total knee replacement because of multiple comorbidities and walking with walker within bedroom to go to bathroom. And when I asked her to walk without walker, no, I'm sorry, this is not available. I don't know. The other day it was available. Today it is not showing up anyway. So this patient started walking, become absolutely pain-free, up and down the stairs, started cooking food for the family and is very happy more than 2 years now. Another patient on wheelchair. For every going outside to airport, she had to book wheelchair. Only within the house she was able to mobilize without wheelchair. Very bad pain for 10 years. And this is how she is 2 years after. Here we did not even do needle plasty because at that time we were not aware of this. And see how the joint space has been restored. So there is repair and restoration with these orthobiologics, and the joint space is restored, correcting the deformity. Now this patient is absolutely pain-free, doing all activities of daily living without any painkiller. Friends, what is the future then? Biological joint reconstruction, I believe, is a viable and realistic goal with regenerative medicine in this day and age. As the knee phenotypes are being described, I think there will be personalized targeted therapy. This will reduce the number of medications and help the patients specifically targeted. Intra-articular genetic therapy has shown wonderful results, not has become routine as yet, but only a few months back there was a new report from Mayo Clinic with very good results. Friends, with newer lab tests, machine learning and AI inputs, day is not far when prediction and prevention of osteoarthritis will also be a reality. I'm very confident in making 2 predictions today based on what is going on, what research is going on around the world and my personal experiences, that in next 5 to 10 years, first prediction, conservative treatment of OA knee, both local and systemic, will be more evolved, and the objective will be help restoration of cartilage, slow down the progression of disease or put the disease in remission. My second prediction is that in next 10 to 15 years, the number of knee replacement surgeries will significantly go down, just like what has happened in rheumatoid arthritis. When I started knee replacement, rheumatoid arthritis was most common indication. Today, hardly any patient of rheumatoid arthritis come because the medications have become so good and effective. Friends, we believe whenever anyone proposes a new treatment, it has to fulfill certain criteria. Over the, if you are trying to go above the routine existing proven treatments and you are proposing a new treatment, there should be certain criteria that it should be simple and affordable. It should be minimally invasive and safe. It should be effective, long-lasting, and should cause disease remission. And there should be enough evidence to practice that. The results should be reproducible, and there should be all regulatory compliance. We should not be on the wrong side of the law. Last but not the least, we can only afford to gamble when there's nothing to lose. So there should be no worsening of symptom and no complications. And we believe this protocol, which we call Ludhiana protocol, ticks all these boxes. So my message for the friends today is that can we predict or prevent osteoarthritis? Not yet, maybe in future. Can we slow down the progression of osteoarthritis? Yes, we can. Can we help cartilage restoration? Yes, and maybe regeneration also in future. Can we put the disease into remission? Yes. Can we postpone the TKR? Definitely, yes, we are doing it every day. Can we avoid TKR? Could be possible in most cases if we start the treatment early. Thank you very much.
Thank you, Naresh sir. I think for enlightening us on joint preservation. So, should we have question answer right now or at the end of the session? We have two questions. Jawahar Jetwa sir is there?
We can have now. If there are only two, we can have now.
Yeah, so we have two questions. First, how do you identify an OA patient at an early stage before significant structural joint damage has occurred?
Well, it is the symptoms. Patient will source. There is clinical radiological evidence we have to have. If patient is having knee pain and the age is nearer the osteoarthritis age, then we do an X-ray, and X-ray will comply with the symptoms. It means it's early osteoarthritis. If it is too early, then maybe we can take the help of MRI, which can show some cartilage damage, which is not visible on X-rays, or maybe it can show bone edema sometimes, but bone edema is a late finding.
So, second question, in patient with early OA, what should be the treatment priority? Symptomatic pain relief alone or also protecting joint function and cartilage?
I would say both. Earlier, it was symptomatic only. But in this day and age, and with what we have learned over the last 5 years, I think protecting the joint function becomes the primary objective, and protecting the joint function and cartilage and putting the disease into remission. That should be our if it is started early. We may be able to save the joint of total knee replacement surgery.
So this is very important point. So you try to give pain relief, immediate pain relief, and also protect joint function and cartilage. And I think we will be discussing about this, how to protect this with conservative treatment or with some pharmacological measure. So now we have Dr. Jawahar Jetwa, senior orthopedic surgeon from Ahmedabad. Sir, over to you.
So, good evening to everybody. Dr. Naveen, Dr. Rajiv Raman, Dr. Naresh Bhai, and all the people from Ajanta Pharma, and all viewers, whosoever is attending this conference. This is a good webinar which we have started thinking that there could be something more which can be highlighted as long as we are now coming up with the IOCON, which is going to be 71st conference in month of December. But before that, we thought that let us have multiple webinars by which we can start some academic discussion, and as a part of academic activity of Indian Orthopedic Association as well as for the Gujarat Orthopedic Association, we are thinking of that let us have some sharing of the knowledge. Now today our main topic is around the knee joint and preservation of the cartilage and delaying or whatever the way we can give comfort to the osteoarthritis, which is a primary osteoarthritis. So let me share my presentation. I think you are able to see my desktop.
Yes, sir.
Yes, and now I'll just start with my presentation. So here it is. I think you are able to see my full screen.
Yes, fantastic.
Right. So thank you very much, Rajiv ji, for introducing me and giving my all details about whatever I could contribute to orthopedics. And this is about the Orthoquest 2.0, the learning modules, where our title is Role of Collagen Type 2 in Post-Arthroscopy Knee Preservation. But basically, what we do in our practice from cartilage injury to osteoarthritis, how we understand and how we try to delay or rather try to cure or sometimes try to help the patient to buy some time, which is very well explained by Dr. Naresh Bhai that what exactly are our aims. There is nothing particular regarding this talk and regarding my views. What we are going to discuss about the reasons for osteoarthritis and what is the role of synovial fluid. What are the indications, mechanism, effectiveness, contraindication, complications of various measures other than surgery? What is the role of collagen type 2 and also flapin, where there can be a combination, bioactive additions, biologics, hyaluronic acid with sorbitol, some methods, illustration, and at the end I will be talking about some summary and in nutshell. Now look at this. Why patients get osteoarthritis? I come across this patient of 68 years of age with a severe tibia vara, but hardly any osteoarthritis. So what is happening? Is it possible that even with this much of deformity, the cartilage is preserved, cartilage is not completely eroded? What could be the level of stability? So we are learning from all the patients, but we are not learning from those who are having such problem, but not, I mean, some deformity, but not that many problems. So there is something more we need to understand about this cartilage, about this disease, which again, Dr. Naresh Bhai has rightly said that this disease is not only of the cartilage, it affects all the tissues. So we need to find out that is it the level of stability which is giving us the problem, and how these patients are moving around without a significant arterial cartilage, even if there is a mechanical, a high degree of tibia vara. So, what are the joints involved when there is an osteoarthritis? Maybe hip, knee, and ankle. So, what are the differences? The hip is well contained, the ankle is shallow. I mean, it is also contained, but not that much as the hip. But the knee is very much shallow. And there is always an age related micro instability. So my point of view is that patient is having tibia vara long back, maybe at the age of 25, 30 years we know. But the arthritic changes starts later, and that is because of the micro instability which has started later. So with this shallow unstable joint, when patient starts after age of 35, 40, 45 years of age, as there was a question that how do you know the early osteoarthritis, especially they start with an early anterior knee pain, the patellofemoral pain, and that is again a micro instability. It is something to do with which occurs more after age 50. So what we need to do primarily is the stability by muscle strength and prevention of the erosion. We have to find out that the repair is more than wear and tear. And how can we increase the repair? We just go ahead with the more and more slides. It is very rightly said that there is no increase in CRP when it is a degenerative osteoarthritis. And that is again, it is now we are understanding that it is an part of an autoimmune disease rather than only a degenerative or friction arthritis. So deformity of the muscle weakness, microinstability where the wear end is more than the repair, there is going to be some more inflammation which is not going to show in increased CRP, but patient is having problem. What could be the other things which we have to consider? There could be lack of exercise, there could be driving on the synovial fluid from the age 30 that has been documented. So after age of 30, from the 31st years of your age, the synovial fluid starts decreasing in volume and decreasing in this viscosity. And that is very, very low, very, very low, that you will be able to realize only after another 30 years that it has gone down. And we have to take care of all comorbidities, obesity, osteosarcopenia, malnutrition, rheumatoid, all those things. But again, as long as it is stable, there is no micro instability started, there is a good tone of muscles, patient is doing good exercise, the knee will remain stable. As long as it is stable, there is less likelihood of early erosion of the cartilage. So synovial fluid, after the age of 30, quality, quantity both deteriorates, and it also varies with the genetics, with lifestyles and overall health. So what are the consequences? When there is a slower cellular regeneration, the cartilage goes on eroding, but at the same time, wear is more, repair is less, and then it increases, it becomes cumulative wear and tear, and then there is an oxidative stress. Now, this oxidative stress in turn is going to go with more and more inflammation, and that will give rise to joint stiffness, achy joints, crepitus, kissing bones. So for us, it is very important that the accumulation of cellular damage from the free radicals affects all tissues, including the joint lining. So all these things are happening because of some sort of a wear and tear, where we need to now understand what could be the cartilage care, what are the injections available, how the exercise lifestyle will work and will help to degenerate, or rather to minimize the degeneration of cartilage. It is very much known to all of us that causes of arthritis may be obesity, mechanical stress, aging, injury, or diabetes, or genetics. And there have been number of publications which are just trying to find out the link between the causes of osteoarthritis. But one thing is which is cannot be avoidable is age. There are number of different pathogenesis which has been explained. Now, why should we intervene early? Now, it is the first question which we had in this discussion was the same, that the moment we find out that in osteoarthritis, it is very important that the cartilage injury, which in turn goes with the matrix disruption, causes inflammation, then collagen 2 degradation starts with a natural degradation, and that leads to osteoarthritis. Can we think of that we had to intervene when the cartilage starts getting injury, starts getting scratching? Maybe after the injury, maybe because of the old age, maybe the instability, maybe the deformity, or maybe any other procedure which has been done, or a malunited fractures. Now, OA is more than wear and tear because it is affecting whole life. It is affecting many things in the patient's day-to-day activity. So, identify the therapeutic window in early cartilage damage is probably a very important aim for the prevention. Now, what is the pathophysiology? It could be immune pathway or it could be 5-LOX pathway. Both are actually going to give rise to some cartilage degeneration. They are different. But basically, one is with the immune pathway and second is with the anti-inflammatory or inflammatory pathways. So, progressive cartilage degradation which occurs. So, we have now identified two pathways. So, we need to target how can we go with two pathways and how can we prevent by giving different medications. So the role of natural compounds for management of osteoarthritis is coming now in more and more knowledge, more sharing, and more in practice. So people have found out that the native undenatured collagen type 2 with aflapine is surely affecting the cartilage degradation. And those compounds are very much responsible for maintaining the cartilage health. Now let us see about the aflapine. Aflapine, in short, is something which is going to suppress the leukotrienes formation, and then in turn it is going to give a anti-inflammatory effect, where the control of osteoarthritis progression and relief of osteoarthritic symptoms will be very good. Now, what we know about aflapine is an innovative synergetic formulation which includes B serrata extract selectively enriched with 20% AKBK, that is along with B serrata. So those things have gone into a more and more clarity, more and pure molecules, and to find out how this aflapine is in a natural way is going to give a good anti-inflammation effect and reduces inflammation. That is our first aim, to reduce inflammation, which in turn reduces the pain. And if the pain is reduced, patient is able to do better exercise. If the patient is able to do better exercise, there will be more stability of the knee joint, and again micro instability will not give rise to more and more cartilage degeneration. Why collagen type 2 matters? Because from the cartilage biology to therapeutic rationale, type 2 collagen has been found to be key structural component of articular cartilage. It supports the proper function of the joints. So we should be aiming at collagen type 2, and it has been found very well with multiple publications that the potential role as an adjuvant in knee osteoarthritis management is. There are so many orthopedic colleagues, my friends, I have found out that they are taking regularly collagen peptide 2. And they have found that somehow or the other it is now giving them pain relief as long as it is in early stages. Now let us see the role of native undenatured collagen type 2. There are multiple, very biomechanical, biochemical, all those procedure. But in short, I can just say that it reduces joint inflammation and promotes cartilage repair. And that is very important when you are using collagen peptide 2. There are multiple combinations people have thought of. With multiple combinations, they have found out multiple studies. People have gone with UC2 versus glucosamine chondroitin, or UC2 with placebo. With evidence, there are evidence in Indian patients. There are combination with conventional analgesic therapy like paracetamol, like tramadol. All these publications are there. They have primarily taken as a parameters like pain, warmth, stiffness, functional tolerability, and they could find out the distinguish between the symptomatic functional benefits from proven structural and disease modifying effects. So as far as the something like injections or something like procedures or something like some intervention, the role of medications is also very, very good when you are thinking of early osteoarthritis. Now, if this is the point, can we go with a multimodal knee preservation, like collagen type 2, and also which is like immune modulation, and aflapine, which is like inflammatory pathway? So there can be a rationale for complementary mechanism, and there are some evidences which are available of the combination. So both can be addressed, and that could be a great way of treating osteoarthritis patient. And why combination of native collagen with aflapine? Because combined together they address major unmet challenges in OA and provide effective management. And on the right side, if you see all the oranges, that is part of aflapine. On the left side, you can see all with the collagen type 2, which are affecting, and there are multiple, minor mechanical, biochemical pathways which can be understood. Now let us see what is the evidence. Now these papers with the highlights of systemic review, meta-analysis, which is effective standardization of BS extracts with aflapine, that is in 2024, they found out that BS supplementation effectively manages OA symptoms, and subgroups analysis suggests that aflapine may offer superior symptom improvement. So people have thought of individual one molecule, but then when they have added, it makes a big difference. And look at this, 9 RCTs with 712 participants included. So it's a really something which worth noting down. Another publication is standardized Bosibilla serrata, which improves the knee functions, cartilage morphology in mild to moderate osteoarthritis. It's a randomized placebo controlled trial 2024, and it says that aflapine supplementation is safe and effective, reduces joint pain, enhances musculoskeletal functions, and improves cartilage morphology in osteoarthritis. Similarly, there are two publications, 2011 and 2023, with a 30-day randomized double-blind study. Both of them, almost the same conclusion is that this study confirms the alpha-plane is clinically efficacious, fast-acting, and safe for managing osteoarthritis with no significant adverse effects observed. Patient can tolerate well, and patient can take for a much longer time. This study in 2013, which is around a randomized double-blind placebo and a controlled trial, which says that daily 40 milligram of undenatured collagen type 2 supplementation improved knee extension, extended pain-free exertion, and elevated joint pain in healthy subjects. So this is how, if it is early detected, if such medications are started, it's going to help the cartilage repair much in a better way. One more is 2015, another articles which conclude that native type 2 collagen combined with acetaminophen is more effective than acetaminophen alone for symptomatic treatment of knee arthritis. So earlier we used to have like naproxen, acetaminophen, or maybe tramadol type of things, which we are just thinking that is initial one, just take an analgesic. But if you add with a native collagen, type 2 collagen, there are now studies which says that it helps in a major way. Now, native collagen type 2 with aflapine management, with his hip and knee both, a single center this prosthesis trial, which says that native collagen type 2 plus there is 40 milligram plus 100 milligram of flapin, significantly improved joint pain, stiffness, and overall OS status by 4 weeks, with further gain by 12 weeks. Now, these 4 weeks are very important. You have to counsel the patient that it is going to take some time, it's not a magic. But as long as they become a very regular in taking this medication, as long as with the exercises, there are good results. The combination was well tolerated and effective for knee or hip. Now, this is a very good study which has recently come. Now, talking about the post arthroscopy, as Dr. Naresh has already discussed about that clinical structure assessment, we can go with a range of motion, strength, and biomechanics, and finding out that reducing the load of inflammation and modifying risk. All these things, all this after checking, once we give such medications, it makes a big difference. What I do in my practice, I also add intra-articular injections. So when do I use intra-articular injections? When all this therapy has not worked, maybe NSAIDs with all these medications where the patient is not able to reduce weight and there is no possibility of modification activity. All those cases when the pain is affecting that activity of daily life or sleep, when they're unfit for the surgery, I think of intra-articular injections. So hyaluronic acid and PRP, there are some of the things which has been now come that giving both together is definitely affecting and definitely superior to alone. And sometimes it gives a long lasting effect because of mechanical as well as protecting cartilage. This is the publication which is about the young adults which are getting the early pain in chondromalacia patelli, the anterior knee pain. All this, when we are giving PRP with HA, it is a very good treatment. It has given good results even in cohort studies. One more thing which has already emphasized by Dr. Naresh Bhai, that oxygen ozone therapy, which is now promising alternative, offering pain relief, functional movements, and it is safe. That has been a systemic reviews. And also the same way, 79 RCTs were 8,761 patients where all these different biologics have been given, including ozones and butylene autoxins and stromal vascular. Now, stromal vascular has been on the top as far as the biologics are concerned. All have given good results, and people are still studying and finding out more and more. Now, what are the recommendations which I say? I would recommend all of you that there is always a published information. We think about evidence. But in your practice, there is a practice information for which we are having this platform. We are discussing, we are finding out from our colleagues, from our superiors, from our patients also, and we get more and more confidence in giving rise to non-operative treatment of osteoarthritis. And usually I ask them to refer the AAOS management of osteoarthritis non-arthroplasty evidence-based guidelines and also from the rheumatology arthritis journal. Why I use hyaluronic acid with sorbitol? Because it is working both way. It becomes visco supplement versus visco adaptive. So not only the viscosity but the elasticity also is improved when we combine hyaluronic acid with sorbitol. Friends, I am giving this in operation theater with a proper abscesses and in lying down position with local anesthesia. But all my patients are always investigated for CBC, ASR, CRP, RBS, uric acid to find out that I am not missing any other pathology inside. After giving this local anesthesia, I just go with the lateral lower quadrant, which is we are very familiar with the arthroscopy people. Then I directly go into the joint, and then I always anesthetize also the part of synovium so the patient becomes very comfortable. And this is how I just seal it. And thereafter, I ask the patient to come every year, although the companies are asking for every 6 months. But in my cases, every year is enough. Now, let's see some of the cases. Like this patient, I am giving for last 14 years. And it is the visco supplement which is the aim of viscosity elasticity. And as I told you, after 30 years it is happening and it triggers the indigenous HA. Now what is this? People may think of that giving 2 ml, 3 ml, 4 ml, or 6 ml, depending on the brands of viscose supplement, it works or it remains in the joint. Maybe for 2 weeks, 3 weeks. It does not happen that way. The moment you give HA inside, the original mechanism of indigenous secretion of HA starts, and that lasts for about 1 year. And that is how the effect of the HA increases. So patients happily come for the repetition, and that is the first sign of success, and that is how it works. Now, this is something where I ask the patient to go with exercise, bone stock, and weight reduction. So, minimal progression after 8 years. You can see something before 8 years, after 8 years, there is a progression, but they are taking every year. One more case 2015 versus 2025. Continuously, I was giving 10 years this visco supplement, no flip section deformity, no laxity. I always have to be very much particular about exercise, bone stock, and also weight reduction, and there has to be a good digestion. Same thing in 2023, 2025. You can see right side, left side. A very bad case, grade 4. Still, patient is very happy. Very old age patient with comorbidity. After counseling, you can pull on such patients and have some good results. This is again for 7 years, 17 and 25. Both the exercises I have taken, I have found out the joint space maintained because of the regular exercise, regular injections at the age of 62. On one more case, she herself is a doctor from 2015. Now, for 15 years, I have been giving these injections, and she is maintaining very well. Although there is a obesity with multiple comorbidities, but there is no fixed flexion deformity, and she is doing well. There is one more case, very bad case, where in this case I could give relief for 6 months, and then patient was undergoing TKR. So friends, adjuvant therapy has a major role. Although you should not forget about the measures like wisely body movements, conditioning exercise, avoid injuries, keep the fitness overall, appropriate pace and goals, and assistive measures. So in conclusion, all those publications, they said there is improved patient's compliance with capsule of once a day only of collagen peptide, which is a combination through their complementary mechanism that both they are going to target mechanical, immune, as well as the anti-inflammatory pathways. The combination of native and aflapine was efficient in reducing pain, inflammation, and joint stiffness, and excellent tolerability. And the combination can slow down the disease progress in osteoarthritis and serve as a safer, effective treatment option in osteoarthritis. These are the things we have to do along with whatever we are doing, like other measures which we are giving intraarticular, also to some extent correcting tibia vara. So the take home message is that from the treating pain, you have to think of that how can you restore the function and you can preserve the knee joint. So intervene early is a very important part. Rehabilitate comprehensively, take all sort of leaflets and explain to the patient, go with the counseling and think of that all these things together is going to give results. Address multiple disease pathways, consider evidence-based adjuvant strategies, and monitor, ask them to come regularly, go with a follow-up and see that what is the progression, and also not thinking of only the pain but also the alignments, also the power, and also some of the parameters which we can think of. So I thank you very much for this opportunity. I think I could give some justice to how we can treat these patients without operative treatment and with the adjuvant of these medications. Thank you very much.
Thank you, Jawahar sir. So we have few questions online, and thanks for the excellent talk on why it is important combination of type 2 collagen with the alpha-sin. We have some question regarding that also. The first question is, what signals in a patient history or presentation tell you that may need more than as needed NSAIDs or analgesic?
Yes, that is what happens. Patients usually with the first or second dose of analgesic, they are very, very happy. And then patients would say, No, I think I had taken, it was a good relief for about 1 week or 1 month, then again I had to take. Then they start taking more and more analgesic, like they are taking every day. Then they start taking twice a day. Then they start taking, increasing the dose. That is the point where you have to think of start giving some adjuvants because only analgesic is not working. And they have a habit of, they may go and try to get it from the chemist directly, so that is the point where we have to counsel them, we have to add some adjuvants. Yes.
Thank you, sir. So, next question is what level of clinical evidence do you typically want to see before adding a nutritional or a adjunct therapy to your osteoarthritis regime? And how do you weigh open level or observational data against that bar?
So that is what exactly I have explained to my talk, that there are all these WOMAC and all these different parameters by which you try to find out the movements and the stability and also the patient's daily activity of life. But very important aspect is that when patient starts telling you that now there is a difficulty in sitting cross leg or difficulty stepping down, stepping up, all those are things which you some idea. But the moment we give these adjuvants and you try to find out, now they are able to do all this activity much in a easier way, less of symptomatic, less of pain. That is how we try to find out that there are the difference. So the activity of daily life is the major aspect of the parameter to find out as an evidence that yes, patient is improving.
Thank you, sir. Next question. How relevant do you see combining an immunomodulatory and anti-inflammatory mechanism in early OA management?
Exactly is my experience. Earlier, I used to give only analgesics. Then I started with whatever glucosamine and other chondroitins were available. Then came collagen peptide 2. At the time, I was not knowing there are some of the medications were available only aflapine or other molecules. There was not such a combination which I started. More so was the problem within our Gujarat, where we are asking, I mean, the patients are asking for a vegetarian source. So we had some problem. But then when we started understanding that combining these two things together with all other parameters, with all other whatever which I giving as a intraarticular injections, that has made and that has given long lasting effect. The only point is that initially, I thought that let me give little low dose or let me give only one. But now I find out with the good combinations, patients are able to tolerate very well, and we are able to see both the effect together. We are not seeing so much of cartilage degeneration. When we go with the MRI with the cartilage mapping, we know that cartilage erosion is not that high as is used to be, and that is how we can find out that combination is definitely working much better way than one molecule alone. Yes.
This is another question, and this is very common question asked by junior also. Role of collagen in osteoarthritis type 3 and 4, advanced osteoarthritis.
Yes, now there are cases where when we see 3 and 4, many a times it is not as accurate as when you go with a multiple observers, you will find out somebody would say 2, somebody would say 3. Maybe the anterior part is 3, maybe the posterior part is 2. Likewise, there are different craters. And sometimes if you are going to give a good stability with a good exercise, there may be a something which is the marginal like 2 going to 3 or 3 going to 4. But in all those cases where patient is having such a limitations because of comorbidity, cannot go for a surgery, they want some relief. They are ready to accept some pain. In all those cases, giving this collagen type 2 will maintain that it is not going to improve, but will maintain and it will delay going from stage 3 to stage 4 or maybe more than that. So that way it affects and it works. That's true.
Another question, any drug better than type 2 collagen for saving knee?
I mean, saving knee is something which probably you cannot ask do anything by which patients can reduce his age. So, we know that it's going to degrade. But at the same time, the demand of daily life also decreases. But at present, I have not found out, except all those biologics which are working on the cellular level. And sometimes, I mean, something which will come up, as Dr. Naisbay said, in genetics in future,
Mhm.
might directly increase the thickness of this cartilage, increase the number of cells in the cartilage. Otherwise, at present, whatever we have, as long as patient is not ready to take injection intra-articular, the medications, these are top of the line is collagen type 2. Yes.
Thank you. So how does cartilage injury increases the risk of osteoarthritis? I think this is obvious. It's a progressive
Obvious.
phenomenon. Yeah.
More because if it is giving rise to a crater, there is a stap, or there is something by which the free radicals are coming up, and it is absolutely in the weight bearing area, naturally, it is going to give rise to early osteoarthritis. Yes.
A very common question asked for the people who give visco supplementation, can we supplement steroid with visco supplementation?
Can supplement
Steroid with visco supplementation for
steroid.
people.
Yes. Now there are now few evidences which has come up. I do not give together, except in those cases where patient is not going to for osteoarthritis for any reason, and patient is just a symptomatic treatment, a grade 4, almost minimal movements. At that point of time, you can give steroids. But those who are very active, when we are getting a good result with only viscose supplement, there is no need to add with the steroids. Although the companies who are now giving a combined as a one formulation, both of things combined, not like we are combining in the operation theater, but it is
Yes, yes.
given, they are giving a very low dose of steroids. So it is basically anti-inflammatory. But in my practice, I am very happy without steroids.
Yeah. And actually that changes the viscosity of the solution also, which is very
Yes.
important. You should maintain it. And that is standardly that is not recommended by any of the visco supplementation.
Yes. Yes.
So one question. So how this alpha me a combination of alpha pin and type 2 collagen can be helpful and can be a future marker for prevention of osteoarthritis.
Yes, so now we know why we know the pathogenesis. We know there are two different pathways. So one pathway is like inflammation, where there are cases, I mean, there are reports like after giving aflapine, maybe from fifth or sixth day, patient starts getting relief of pain. So that shows that anti-inflammatory effect. But as far the collagen type 2 is concerned, maybe after 20 days or 25 days, they start getting some analgesia. So that is an immune pathway, and that is also supporting the collagen repair. So when we are going to have both pathway targeted, naturally we are going to get a better results. So combination is not like simply doubling up with the same effective pathway. Both are different pathway, and synergisty is has been approved by the various publication. So I think combination is good.
So after using the native type 2 collagen and alpha pin, there's another question. Can we delay the surgery? And if so, by how many years?
Yes. Now this depends on if you are with a grade 1, grade 2, and if there
Yes.
is no mechanical varus, no mechanical deformity. If there is a significant mechanical deformity, somehow the other is going to deteriorate. Unless you do something, unless you try to find out. So my take is like a significant tibia vara with grade 2, I tell them do not wait, get it corrected, because simple medicine is not going to make your limb straight. But other cases, yes, depending on the patient's compliance. As I've shown you my cases, 17 years, 15 years, 20 years, they pull on. So we can delay as per as the patient's compliance, patient understanding, and the patient's overall lifestyles.
Sir, Dr. Jitwa Jawar
Yes.
Bhai,
Yes.
I have a question because
Yes.
on this subject, are
Mm.
there any studies that you are aware of
Mm.
which are double-blind, random control,
Mm.
non-industry supported studies on
Mm.
alpha pin or collagen showing benefit of cartilage preservation or restoration?
Non-industrial, no. Non-industrial, it is difficult,
So
but
that means all studies are industry supported.
No, no.
Number one.
One more thing very important. Flavonoids. Now we know NSAIDs. The flavonoids is something which has come up, and there are a number of publications in the pharma, also in Ayurveda. They have similar type of compound they have thought of. When I was just preparing for all such things earlier, I used to find out some of the publications from the pharmacology, some of the publications from the Ayurveda, which is combined one like no herbal preparations, natural preparations, all of them ultimately going with the same pathway. So
That
you are
is
right
all
that
right. My
huh.
question is very specific. Are there any clinical, single or double blind, random
No,
controlled trials,
specifically it is not.
non-industry supported, which have shown benefit of either
No.
aflapin or
No, no,
denatured
that
corrigan?
way, sir, specifically as you are asking, that I have not come across.
No, thank you. Thank you.
So thank you, Naresh sir, and thank you, Jawahar sir, for enlightening us. So I think there's one more question. Role of calcium supplement in osteoarthritis by Dr. Nilesh Kattani.
No,
So
that is very simple. That if patient is developing osteoporosis, osteopenia, and sometimes osteosarcopenia, we need to see that the bone stock is good. So ultimately, if the platform on which we are putting the weight and the tibial plateau, if it is going to go denting inside, naturally the amount of friction will increase. So we need to see that bone stock is maintained. So in all those cases where it is going to give rise to some sort of osteopenia, calcium supplements are always good. And we know about the vitamin D3. It's affecting almost all the systems of the body. So it is naturally very
Uh,
important.
I, I, I will have a small, slightly different take. You know what happens in osteoporosis?
Hmm.
The bone calcium comes into the bloodstream.
Hmm.
yes,
It's a deletion of calcium from bone, so it comes into bloodstream. So if we further load the bloodstream with calcium, it will only get deposited elsewhere. It has
Hmm.
been shown now that atherosclerosis is more. So here, why the calcium? We have to find out the cause and address that. Why calcium is getting depleted from bone and coming to bloodstream? This is a hormonal imbalance. So we have to correct the hormonal balance, including vitamin D, which is a hormone. So that is what is more important than giving calcium supplements. Calcium supplements only if serum calcium is low. Then along with hormonal balance, we have to give calcium so that calcium starts going back to bone.
Right.
Otherwise, earlier I used to give calcium to everybody. Now I don't give to anybody because
Hmm.
calcium is already more in blood. So
Hmm.
I only correct metabolic imbalance, hormonal imbalance, vitamin D imbalance, and if there is hypocalcemia, only then oral calcium.
Maybe the part of the food also
Yeah,
is
that is
enough.
the food is enough for
Enough.
normal.
Yes.
If the
Yes.
serum calcium is normal, your dietary calcium is enough.
Is enough. Yes. Yes, sir.
thank you, Naresh sir, for enlightening us. So I think we don't have any more question in the chat box. So thanks to both the national faculty.
Rajiv, you checked both the sites for question?
Yes, yes, I have seen.
Both link, both link.
No, only one, the link where we have questions here only, sir.
No,
The
no,
last,
other link is also questions.
oh, I could not see. I have the question in the chat box only.
Now, I
No,
am
no, other link. It is telecasted at two places.
Any more questions, Sushant? Because that link I have not checked. Last question in this link is role of calcium
Mr.
supplement already answered.
Mr. Jana, is there another link?
There are few questions actually. It is
I
already
think
posted.
repetition was there, sir. So they have scrutinized, they have just
Okay. Okay. Okay.
compiled
No,
all the
no,
questions,
no,
sir.
no. On the other platform of Iocon, is there a questions?
And Jawar sir, I have forwarded you the trial details of what
Right.
actually Naresh sir is asking. Can you please see the WhatsApp, please?
What's up? Okay. Some of them you might have sent on WhatsApp.
Sushant Bhai. Is Mr. Sushanta
Yes, sir.
Just out of curiosity, I wanted to know how many people have been listening to this webinar.
It is, sir, 1100 plus.
Oh, I'm really very surprised at
Yes,
this.
sir. We can share the Excel sheet also. Who
Sir,
has
sir,
joined this?
Can you
sir,
share me the link?
Yes,
sir,
yes.
we'll have to give to the NMC, Gujarat Medical Council, for getting the credit hours.
Yes,
So we
yes.
have noted their email ID, their name, their city, and the mobile number.
Everything is there, sir.
Yeah, everything is there, sir, on the both the platforms, sir.
So, Naresha, there is one more question in the chat box for you. What challenges do you face in ensuring long-term treatment adherence in early osteoarthritic patients, especially when symptoms improves after a few weeks?
Yes, there are challenges. Patient, once the symptoms improve, patient don't come, they don't follow up. We have the record of all the patients we keep. We sometimes telephonically follow up for the purpose of, if we want to publish anything. But yes, if the patient improve within 2-3 months, then they are lost to follow. Then they come after a few years when there is recurrence of symptoms. That is true. That is typical of our country, and that is everywhere. I can't deny that.
I just had
I have to only counsel the patient that they must continue regularly. I usually, my frequency of follow-up from earlier monthly or twice a week in the first month, and then monthly, then 2 months. And then eventually I make it 3 to 6 months follow-up. I tell them, you come to me at least twice a year and just say hello.
Thank you. I think
Naresh
Jawahar sir
bhai,
will share some trials. Yes, sir. Report. Yes.
Naresh bhai, it is just, I just received this. There is a publication in February 2022 which is exclusive on aflapine, where they have found out with their uh, randomized double-blind placebo-controlled clinical study,
Yes, sir.
and they have come across that yes,
Is it
ultimately.
so that is the only study and which is non-industry supported.
And that is
Yes,
that. What is the conclusion? Is that this investigation affirms that the aflapine is clinically efficacious, fast-acting, and safe in the management of osteoarthritis.
Thank
No
you.
significant adverse effect. Now
all right.
that is something which is now, as long as the patient, I mean, doctors are using
No,
more and
I
more.
know. I have been personally using aflapine,
Yes.
collagen, and I know
Mhm.
that they are helpful.
Yes.
But
Yes.
there has to be a neutral scientific evidence.
Yes. Yes.
Yes,
Yes.
sir. So that trial acting thing Dr. Jawahar Jetwa was doing. So Jawahar sir, any more trial study? I think two studies Sushant has
Is
shared. Yeah.
that trial that you mentioned now, is that also from India? Because earlier aflapine, all studies were from India.
Yes. 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 I mean, what I can share with you, Naresh Bhai, that this is something which I just have a conclusion type of things. We can go into detail of this particular study, but
Yes, sir.
it is challenging. It is good. It is adding to our knowledge.
Thank you, sir.
Yes. Yes.
So uh, Sushant, any more question? I think.
No, sir. Almost all questions. And I have shared the attendee details to Naresh sir also.
Yeah,
Yes,
all right, all
yes.
right. Thank you, Shashank. And thanks for this wonderful webinar from cartilage injury to osteoarthritis. Thanks to Naveen sir. And a special thanks to Dr. Jawahar Jetwa and Dr. N.K. Agrawal sir and our NMC observer. So Dr. Keur Patel for being here. And he is observer from Gujarat Medical Council. So over to you, Team Ajanta. Sushant.
Dr. Q has come.
So he was there, sir. He was there. He has left.
Yeah,
I
yes,
think
yes,
he
yes.
is there.
I request Ajanta Pharma to give the vote of thanks.
Dekho.
Ajanta Pharma, give vote of
Yeah,
thanks. Anyone from Ajanta Pharma?
good evening. Yeah, good evening. I'm Pamela from Ajanta Pharma from the marketing department. I would first, of course, on behalf of Ajanta Pharma, thank Dr. Naveen Thakkar and, of course, Dr. Rajiv Raman for, of course, giving his valuable time to be a part of this initiative. And a lot of thanks, of course, to Dr. Jethwa and Dr. Naresh Agarwal for the lucid and insightful presentation, which was beautifully complemented by the interesting case study presentation. The clarity and the practical approach made the session much more very encouraging and very enriching. And of course, not to forget, and the Indian Orthopedic Association for again giving us the opportunity to be associated with them for this wonderful initiative. And we truly value this association and look forward to many more collaborations with you in the future. And lastly, not to forget, of course, Jana sir and Jester for making this coordination a very seamless one. Thank you, everybody, all the delegates, and good night to all of you.
Thank you.
Thank you. Thank you.
Thank
Thank
you.
you.
Thank you.
Thank you so much.
Bye.
Thank you.
Naresh
And
bhai.
good night.
Satisfied, Mr. Susanji, are you satisfied with both the platforms? Relay.
Yes, sir. It was definitely good, and we'll improve better because